I'll try and...
This is the lady that's in charge of it.
Okay.
Can you see, sir?
Oh, yeah, I'm fine. I'm fine. Absolutely fine.
Okay.
So you tell me when you're ready.
We're ready.
Okay. To begin with, I want to thank Purdue Frederick for sponsoring me to my participation today, as well as the, from what I understand, the Department of Veterans Affairs for convening this conference and sort of helping us to refocus our cumulative attention on the very important subject of ethics, particularly in medicine and with the subspecialty in chronic pain medicine. I'm particularly happy to be able to participate and join our conferees. I'm not sure where else the teleconference is being satellite conferenced to, but I want to thank all the attendees and participants here today. My lecture today is actually going to be a distillation of knowledge imparted to me by several physicians as well as medical ethicists, in particular Linda Emanuel, who's an MD PhD, from whom a large part of this slide presentation is a distillate. But more importantly, I want to thank my patients and the patients of all the physicians who are in attendance today, who really, their experiences are really serving as the body of our growing ethical experience. And it's really from them that we're able to have a discussion about the evolving nature of medical ethics and the challenges that poses. Today, I want to address several ethical principles, discuss associated concerns regarding those principles, and then have a collective discussion with all the participants regarding medical ethics in the form of a case presentation. Actually, I have a couple of case presentations that I want to give today. And I do this to emphasize the point that, to paraphrase the great Irish-American politician Tip O'Neill, that ethics, like politics, is very much local. And what I hope to convince everybody today is that there is no right or wrong answer to the ethical considerations that we have. But more importantly, there are some absolute principles involved that need to be followed in any logical discussion of an ethical dilemma. And the importance of this is paramount as our pharmacologic and medical technological data and technology logarithmically improve. The ethical considerations, the ethical problems that we have to consider are also going to get increasingly complex. I think that we have certainly a professional imperative, and certainly to cure is a very real concern, but more importantly in chronic pain medicine, we deal with the professional imperatives regarding comforting patients and avoiding harm. We certainly want to cling to the concept of primum non nocere in our ability to comfort patients, but here we want to adhere to our first real principle, and that is we want to avoid malfeasance. And what I mean by this is we want to provide competent, comforting, professional medical care in a trustworthiness fashion with really no ulterior motives. For pain medication, we know for pain medicine in general, certainly there are certifying agencies now where one can become board certified in pain medicine. But that's not to presuppose that all concerns or ethical dilemmas involving the issue of pain medicine is relegated to board certified specialists. Rather, as I hope I'll convince you after the case presentations, board certified specialists we should be considered as a resource to physicians. And the principle that we have here is really to prescribe the adequate and correct pharmacologic agent to patients in order to control suffering, but to do it in a manner so that we avoid adverse side effects. All the while respecting a third major principle, and that is the autonomy of patients. The autonomy to participate not only in their care, but autonomy as patients, and more importantly, the autonomy that we should also consider with respect to the patient's delegation of their authority to a trusted third party that has already been sanctioned, whether legally or religiously or in many ways. So our practice environment today has several different barriers to good care, as well as a general overview with respect to pharmacologic agents, and that certainly for chronic pain medicine involves the underuse or overuse of medications, and there's certainly legal considerations that I'll explore during the case presentations with you. I just recently came back from the AAPM meeting in New Orleans, in which a case presentation was given regarding a physician who was actually sued for under-prescribing pain medications in a terminally ill patient. And I think we need to bring that to bear when we have some of our ethical considerations today. But certainly there are many other barriers to appropriate use of pain medications or non-pharmacologic treatment modalities that we need to consider. With respect to the various stages in life, there are specific concerns that we need to keep in mind. End-of-life care, both in the geriatric and pediatric patient population, are very real and probably some of the biggest ethical considerations and burdens that we as physicians have. The perioperative considerations regarding advanced directives is also a very real consideration that we need to pay special attention to. Chronic illness poses its own challenge because in many cases the terminal life, the terminal illness issues, the end-of-life issues take on a different spin as patients are growing older with some diseases that 5 and 10 years ago were terminal diagnoses. AIDS is a perfect example of that. The barriers to good care regarding human factors, as mundane as transportation, all the way up to access to care, and particularly at research institutions, are also very real considerations that we need to keep in mind as we go forward. Some of the barriers to good care regard our own preconception of the end-of-life issues and the end-of-life issues regarding the patients themselves. We have a growing body of data, some of it international in scope, particularly out of the Netherlands, which is the only Western nation, developed country to sanction euthanasia. And that really regards some issues regarding this deal with, do the dying suffer? I mean, are there very real concerns? Well, in fact, we know that from New England Journal of Medicine report that over 50% report moderate to severe pain in terminal, in end-of-life issues. 10% of these patients or more require additional medications, or certainly wanting additional medications, and many of those not getting them. 90% of these patients have comorbid medical problems which mandate inpatient care, and as you would expect, the inpatient patients are going to have more comorbid medical problems than patients in hospice care or outpatient care. Some of the ongoing concerns for patients with respect to suffering revolve around non-pain related items such as nausea, vomiting, incontinence, constipation, weight loss, asthenia, loss of function, being a burden on family members, confusion, depression, and anxiety. Obviously, some of the asthenic symptoms, the confusion issues, depression, can actually be side effects to the medications or the armamentarium we use to deal with some of these end-of-life issues. And in that particular case, many of the side effects may actually be a barrier to good care if patients aren't adequately educated beforehand. In the pediatric population, we have a growing body of literature now dealing with respect to the fact that terminal illnesses in pediatric patients actually do cause a tremendous amount of pain and suffering. 82% of patients have severe chronic lingering type of painful conditions. But if adequately treated, parents for these patients also report that overwhelmingly large numbers of pediatric patients have successful treatment in dealing with both chronic pain issues as well as end-of-life issues. Some of the barriers to these end-of-life care, as well as barriers to overall good medical care not relating to medical management of pain, had to do with the perception on the part of physicians of patients being difficult. In other words, they're so complex, they have a terminal illness, I'm not even going to bother dealing with these as we probably should be. In other words, they're perceived as difficult patients. The patients themselves may be in denial, particularly prevalent in pediatric patients where the parents are not, they're just in a still state of disbelief and denial, as Elizabeth Kubler-Ross would teach us, about their child having a terminal illness. On the part of some patients, and you hear this quite chronically with older patients, there's a real fear of addiction. They don't want to lose that control mechanism for their own medical care over to either a physician or to some perceived pain medication, which has a negative connotation. And this is, we deal with this all the time in pain medicine, particularly regarding medications such as methadone or morphine or hydromorphone, where the morphinoid sort of name has a connotation to certain patients, and it's that relinquishing of control that many patients don't particularly care for. And then, of course, the side effect profile, if you don't educate patients properly, can be a real barrier to good continued medical care of chronic pain, because they immediately will discount any further use of these pain medications if they have obtundation, respiratory depression, constipation, incontinence, any number of side effects. And then the social and personal connotations. How much control they're going to be giving over. Am I going to be isolated, not surrounded by my social support network because I'm taking these medications? Or I have a epidural catheter. Is it going to allow me to get out and participate with my family like the way what I'd like to? So all these barriers are perceptions on the part of physicians or patients, which can be a real impediment to good medical management. I want to address, with respect to physician education, several issues which are very, very important. And I think need to be on our radar screen as we go forward in the discussion of the ethical management of chronic pain. And that has to do with addiction. And certainly we are well aware of the fact that addiction itself is very well defined. And it's basically an overuse, a dependence upon certain medications where there's a compulsion, a use, a behavior that is not normal or conducive to a normal functional daily life. But what I also want to have a discussion with today is the fact that addiction, while we certainly use it in conjunction with substance use or abuse, that the notion of pseudo-addiction is actually born out of our collective ignorance of what is truly addiction. And basically, the concept of pseudo-addiction has been borne out by an increasingly large number of patients who are basically been undertreated for their chronic pain condition, no matter what the cause, whether it's a chronic non-malignant pain syndrome, such as failed back patients, or patients with metastatic disease who are being prescribed minimal doses of Tylenol with codeine. The fact is that these patients are labeled as addicts because in their desperate attempts to go from physician to physician to physician to find the right relationship that's going to adequately treat their pain, they are perceived as addicts because they're using an inappropriately large amount of a medication that is really not indicated for the level of disease that they have. And once properly diagnosed and treated with the appropriate medication, the addictive behaviors go away. And that is the hallmark of pseudo-addiction. And it's a subtle distinction, certainly, but it's a very real one. And one which I'll point out is just as very real a distinction between tolerance and physical dependence as is pseudo-addiction and addiction. Tolerance is basically a physical symptom that we all can manifest, where we have repeated exposures to a certain pharmacologic agent where over time a given dose is not as effective as it was. Now, this is very easily demonstrated in most of us by the fact that we've all taken at some point frequent doses of NSAIDs, whether it is Motrin, Talectin, Voltaren, whatever. If we're on it for a specific period of time, we will become tolerant to its use, where we have to take more to get the perceived desired pharmacologic effect or switch to another agent. In contradistinction, physical dependence is actually a process of neuroadaptation. And it's demonstrated by the fact that when you withdraw that medication, there's a withdrawal symptom. Now, this is very prevalent with beta blockers and also with opioids. And the distinction here from a physiologic standpoint has to do with up or down regulation of cellular receptors. And the fact is that we know that certain classes of medications are going to exhibit physical dependence characterized by withdrawal symptoms, and that if changes in these medications need to be adapted, then reductions in the dose need to be done in an incremental fashion while we're substituting alternative medications to better treat the chronic pain condition or terminal condition. And the fact is that we do have substance users and abusers. And the concept I like to put here is the fact that even though you're paranoid, it doesn't mean that somebody's not after you. And the fact is that substance abusers or abusers can have pain too. And And what we mean by that is that if folks are labeled as addicts and in fact have been documented to have been abusing substances, whether it's alcohol or prescription pain medications, the fact that they may have in fact a very real underlying painful condition should not abrogate your attempts to accomplish a good history and physical. Because in fact, protocols and contracting with patients are a very real way of dealing with these patients, of setting limits, but appropriately treating chronic pain. And I want to stress the fact that if patients present to you your practice and you don't feel comfortable dealing with their chronic non-malignant or malignant painful condition, this is the point at which a board-certified physician may become a valuable resource to your practice in dealing with those patients. With respect to end-of-life issues, certainly one of the biggest, most politically charged issues has to do with physician-assisted suicide. And from Dutch data, we know that 3% of patients who have an interest in having their physician assist them with suicide or euthanasia, only 3% of those patients actually quote pain as the sole single reason for them to be euthanized. The vast majority of these patients cite pain among other issues, but other issues are the real reason why they are seeking physician-assisted suicide or PAS. What are some of these other risk factors? Well, certainly we know that patients with high depression scores are at risk for inappropriately undergoing physician-assisted suicide. Unmet care needs or the sense of being a burden to family members or the social structure are also ethical considerations, but they're really not high on the logical ethical consideration. Indeed, ethical arguments associated with intractable pain are probably some of the strongest, but the vast minority of cases where patients could actually be considered candidates for physician-assisted suicide. And I think this is really where the ethical dilemma with physicians such as Jack Kevorkian have come to the forefront, is what are the ethical considerations for certain patients, what are the indications for physician-assisted suicide, and certainly physician-assisted suicide as a solution to psychosocial suffering is actually a weak intellectual argument. When we consider the terminal end-of-life issues, we certainly know that end-of-life issues correlating with physician-assisted suicide it comes in certain guises. Sheep's clothing is rather well known, and certainly the use of potassium chloride or neuromuscular blocking agents characterize physician-assisted suicide as opposed to the normal expiration for a patient because of natural causes. While we certainly want to have competent relief of suffering for terminal end-of-life issues, rarely does that care cause respiratory depression. And more importantly, the concept here is that we want to sedate patients, but do it at a level to which suffering, only suffering requires the sedation to occur. And that we should ethically allow death attributed to an underlying illness, or at least have that consideration in your ethical decision-making process with the family as well as the social support system with which you're sort of leading them through that intellectual process. A concept that I want to discuss today that's very well known in the ethics of chronic pain medicine as well as ethics in medical care today has to do with the doctrine of double effect. And what this is basically purporting to say is that there is an unintended but a very predictable effect that's necessitated by a desired effect. And that's very common in medicine. For example, chemotherapy and alopecia, beta blockers and impotence, and in chronic pain medicine, the use of opioids and the virtual 100% incidence of constipation, the large prevalence of side effects such as asthenia, lethargy, and impotence. And basically, the notion here is that the desired effect is justified by the greater good and that the incidence of side effects are an accepted incidence. Rarely, however, should the doctrine of double effect apply to proper terminal sedation. In other words, the hypocritical use of this concept actually causes confusion. And what I mean by this is that what we don't want to do is have an equal or greater predictable effect have a larger consideration in our ethical dilemma or consideration of a logical end. And by that, what I mean is that respiratory depression in a COPD patient is simply an acceptable side effect when giving IV PCA morphine. Well, the fact is that in that ethical dilemma, perhaps IV PCA therapy for a terminal patient may be an acceptable alternative. The choice of morphine in a COPD patient may not be the best acceptable medication. There is a viable alternative, and that should be sought out with the use of consultation. And that's really where the hypocritical use of the doctrine of double effect actually comes into play. Additional barriers of good medical care, certainly in the ethical dilemma, certainly revolves around professional considerations such as state licensing boards, federal state mandates, opposition to states' rights in some particular cases, the ability to control on a state level what defines euthanasia, the consideration in Washington and Oregon now of whether their state laws for euthanasia actually have applicability or should stand or are actually being tested in the courts. Certainly we know that access to care is a very real barrier, and in fact, 80% of analgesic morphine used worldwide is used in the 10 most advanced countries. The 120 of the poor countries have little or no use simply because the medication is not even available. So in summary, before we get to the case presentations, I think that we need to give due consideration to the professional imperatives that we have as physicians, keeping in mind the principles that we have discussed, that we have certainly practice parameters that we know where end-of-life care, the ethical considerations, whether in the pediatric or geriatric population, are going to be paramount, but that there are very real barriers to good care regarding the terminal life and end-of-life care, whether it has to deal with medical education for physicians and patients, all the way to our own personal cultural and religious biases. And what I'd like to do now is discuss the first case and make this available for discussion with our attendees both here as well as the teleconference. And let me read for you the case in its entirety. I've provided a synopsis here. The first case is a 69-year-old woman with metastatic breast cancer who's at end of life. She's referred for pain control with diffuse neurogenic and osteogenic pain due to bone and brain metastases. Family and church friends are much involved, including open prayer for healing. And the patient and family specifically rule out psychologic techniques or psychiatry as part of their care. However, the patient specifically and privately requests the use of drugs for pain relief to her physician. Contrarily, the husband, who has power of attorney, and the family pass on instructions that drugs are definitely not to be used. And in fact, recourse was threatened if we did not follow up on this instruction. There are no other advanced directives on the part of the patient, and the hospice staff where we're taking care of the patient is wringing their hands as the patient vocalizes severe suffering but refuses oral intake or any comforting attempts, and she only wants the shots. So the first question I would pose to the attendees is, should we allow this patient to suffer? And if not, why not? And what are some of the ethical considerations you would give to this particular patient? Now, if we can certainly start at our teleconference attendees and go there first. Who do we have on the line?
I have Carvel on the line, and I just think it should be the patient's decision and not the family's decision. And I think there's a trust that should be between the patient and the physician that allows that decision-making to be done.
In spite of the fact that the family who has the power of attorney is vocalizing their concern, what would you do about the very real threat legally that the family poses?
Harriet, it's called Catherine Edwards. I would think that we have a legal foothold, or whatever you want to call it, to be able to manage the pain, because we do have an obligation to manage pain, and particularly at the request of the patient.
What's the local physician feeling on this ethical consideration?
The patient obviously looks like she's competent side of the legal threat that the family is posing, because patient does have pain and she does need, and I think that counts first before anything else. And the legal guardianship is in when patient is not able to make her decision. So as long as she's able to make decisions, that doesn't play a role.
Are there any other views that anyone would like to express?
If patient is competent enough, then she can make her own decision and to go with the IV or intramuscular, whatever the analgesic she wants for that pain.
The situation evolves, and the family, now that you've sort of positioned yourself between the family and the patient, the family demonstrates even more aggressiveness and solicits two physician opinions, both of whom corroborate the fact that this patient is not competent to make their own decision, and that the legal guardianship to the husband is not only a binding legal document, but a medical document as well. What are you going to do at this point that the patient's been considered incompetent to make a medical determination?
I would have a question as to why the family is so adamant about allowing this person to continue suffering when they are asking for drugs. I cannot fathom why they would be so adamant.
And that's, you actually hit the nail right on the head, and that's the point that I think we need to consider, and that is, again, we need to go back to the notion that there is no right or wrong answer in an ethical dilemma, but that there are absolute principles that you need to keep in mind. And this goes back to what we talked about before in terms of doing no harm. And when I say that, what I mean is doing no harm not just to the patient and their medical considerations, but the fact that this patient depends upon their social support system, not just for medication, but for a great many other things. And I think one of the considerations we have to keep in mind is we never ever want to pose ourselves between a social support system and the patient. In fact, if anything, I think with respect to end-of-life issues, we need to involve the families earlier rather than later before it gets to the notion of it's us versus them, and really educate people that, if you find yourself in an ethical dilemma where there are contrary views being expressed to what you know is in the best interest of the patient, I think it behooves us as physicians to sit down and educate either a contrary physician opinion, a contrary patient opinion, or a contrary family opinion as to what is in the patient's best interest. Now, it may very well be that you sit down and you undergo this logical discussion of what's in the patient's best interest, but that at the end of the conversation, there has to be a decision made. And that decision can be one of several things, but typically it's this. Either we are going to agree, or we're going to agree to disagree. And at which point, if you do not wish my participation in the care of this patient, then we have to agree that an alternative physician will be found to assume the patient's care, and that all agree that this would be in the best interest of the patient and the support system. In other words, we haven't really gotten an absolute answer, certainly the answer that you might like, but it's the answer that the patient might like and or the family and social support system might find best. Are there any other issues regarding this case that anyone would like to discuss?
I have a question about once you did get to that point, for example, and the family insisted, say, that you did stay on the case, does it come down to then a matter of legally who is actually going to make the decision? I mean, is that the ultimate bottom line if it really gets down to it?
Well, I think in that particular case, in my practice, I've yet to find a family where, absent, for example, a Jehovah's Witness and the transfusion issue, where an adequate explanation of what we can accomplish with proper pain medicine, where that doesn't resolve a great deal of their angst and anxiety and concern about the use of these medications and the treatment of chronic pain. But I think that the issue is that we think about that up front and keep in the back of your mind that there may be an outcome that you may not like, but that if you properly educate patients and their support system, that a great deal of these conflicts can be resolved without ever really having to deal with them when you get into an adversarial relationship. And we've all been in the situation where emotions are running very, very high. There's a great deal of angst about grandmother who's dying and the fact that this is what she would have wanted and I know her best. And so I think that these are concerns that need to be in a loving and caring manner explained to the family. And if it gets to the point where, as a professional, you don't feel you can properly take care of the patient as you would recommend that they would be taken care of, then it's incumbent upon us as physicians to work with the family cooperatively or the patient cooperatively to find the physician who can take care of the patient in the manner that the patient and or the family so chooses. The second case is the following. We have a 36-year-old preemie who's unable to be weaned off a ventilator despite multiple attempts secondary to congenital abnormalities. The attending physician has had an excellent rapport with the parents through the entire hospital course and explains to the bereaved parents of the terminal nature of the child's medical diagnoses. There is an acknowledged acceptance on the part of the patient, and the patient thoroughly explains the logical plan to the parents of how they're going to withdraw life support measures. The mother is allowed to hold the child while the physician concurrently administers opioid analgesics, sedative hypnotics, as well as neuromuscular junction blockers. There's a peaceful terminal outcome for which the parents are extremely grateful. However, a lone dissenting staff member of the hospital does not accept this and brings the physician before the ethics committee. Is there any part of the care of this patient for which the physician could be faulted? And again, I'll go back to the teleconference participants, I believe in Kerrville, is that correct?
That's right.
I don't see any, to me, the physician is not at fault.
Maybe the physician could have worked with the staff a little more closely to allow them to know how that care may have been managed prior to it being done.
Is there any part of this physician's plan, and I'll open it up locally or anywhere else, where a physician might be faulted by peers with respect to what we've discussed in our presentation regarding his plan?
The use of muscular blocking agents starts to take a sort of a more passive, supporting kind of care, to more of a potentially active physician-assisted suicide type of status. And I guess personally I would have trouble with giving a muscular blocking agent. Opioids you could rationalize, to relieve pain that the child may be having. Benzodiazepines if the patient has been having seizures, I think would be reasonable, but the muscular blocking agent is best in a gray zone in my opinion.
Okay. How about if we'd substituted a high dose of like 100 milliequivalents of potassium chloride in lieu of a neuromuscular junction blocker? Would that resolve the ethical dilemma in anyone's mind?
It still falls under agent.
Exactly. And I think, are there any other opinions from the teleconference participants?
Not from Kerrville.
Okay. All right. I think that, go ahead.
I was just wondering why the child was on the vent to begin with.
Well, the child had a history of seizures, was not capable of supporting his own ventilation, and being a preemie with underdeveloped lungs, there was, and again, rather than getting into the specifics, the pathophysiologic specifics, I just wanted to throw that out as a concept that the patient was ventilatory dependent and was not able to be weaned off the ventilator and will never be able to be weaned off the ventilator despite multiple challenges.
And that was clear to all the staff?
Yes, yes.
Okay.
Again, I think the concept that I wanted to bring out in this particular case presentation is that despite the best attempt, despite getting the acquiescence of the integral parties associated with what was a terminal life event, that there is an ethical consideration to each and every step along the way. And I think from an ethical standpoint, there could be some question as to the use of the muscular blocking agent as a integral part of the plan for terminal care for this child. It begs the question certainly of whether the child would have been in respiratory distress and gasping for air and in insufferable pain as the child expired. And the ethics committee in this particular case, obviously, the results of that are not released, but it is simply out there for discussion. And it demonstrates the point that no matter how clear-cut the situation, that there is no right or wrong explanation or answer to a resolution, that everything we do, particularly in certain areas of medical practice, are going to have ethical considerations for which both a pro and a con are going to be able to rationally be argued. And I think the more important part of this whole consideration and why it's so important, and certainly why the state of Texas is now mandating ethics education as part of our ongoing credentialing as physicians, is that there are so many things that we do and we take for granted without thinking of the implications, that it is truly time in our collective interest to stop and take a good hard look exactly what we're doing, because there are a whole host of medical practices, for example, patients in florid sepsis who are close to death, who are treated with antibiotics. Well, why? There are patients who are effectively ventilator dependent, who have only brainstem function, for whom the family may come and say, I want this patient, I want my grandmother, I want my grandfather to be on high-dose opioids, when in fact you can sit down and explain to them that there is no higher cortical function, there is no cortical perception of pain, and that the use of expensive medications is simply not warranted, and this may not suffice for the family. And if it doesn't, how are you going to ethically resolve that? Are you going to stay on the case as a physician? Are you going to recuse yourself and tell the family that you need to find another doc because I can't condone this? I think that there are a great deal, there are a whole host of things in medicine that we have done by rote that we need to seriously go back and rethink and arrive at your own conclusion. Again, quote Tip O'Neill, politics, ethics like politics is local. It's a very personal decision that you and your patient and the support system have got to resolve. That pretty much concludes my presentation today, and I would certainly welcome any questions that anyone would have. And I, again, want to thank Purdue Frederick for sponsoring my participation today, and truly want to thank the Department of Veterans Affairs for bringing this very expensive, I'm sure, teleconference concerning medical ethics, and particularly ethics in chronic pain. The one point that I do want to emphasize is that the notion of advanced directives for patients truly is an under-resourced concept. It's one where patients need more education and would resolve probably a lot of terminal end-of-life issues, because in many respects, family members simply don't know the final wishes for their beloved ones. And I know when my mother passed away, fortunately for her it was very, very quickly, but had she lingered, I'm not sure I could have answered some of these questions. I'm not sure I could have discussed intelligently what her desires are despite the fact that she was an extremely stoic individual. So having these discussions, particularly with loved ones or your patients, and having advanced directives, I think is a very real concept whose time has come. And again, I would be more than willing to sit and answer any questions any of the teleconference participants would have, or locally. And I'll open the floor now for questions. If there are none, again, thank you so much and for your participation, and have a good weekend.